Alright, hey, what's going on, guys? It's AJ here. I'm just going to give you, for our first portion of our lecture here, we're going to be going over neonatology. So, to quickly go over what a neonate is, it's going to be any patient that is 1 month or younger. There's going to be plenty of little special considerations dealing with their heart and their lungs, their airway, the way that they can present their central nervous system, and a bunch of abnormalities that can happen with inside their abdominal cavity and special considerations for their metabolic demands. Um, so our patients may require suctioning, mild stimulation, and body temp regulation. Our biggest one here is going to be body temp regulation, assuming that they didn't need these two. Suctioning is only going to be considered in the fact that they do not have airway patency when they come out of the mother's womb. And mild stimulation, maybe they got a shit APGAR score, so just a little tactile flick or rubbing in the back or blow by O2 to facilitate their ventilations or respiratory rate. The most common cause of our loss of heat is going to be our convection. So we already know stuff like antepartum and intrapartum. We already know the predispositions for, let's say, preeclampsia and eclampsia. What kind of justifies how they go to the eclamptic stage is going to be seizures. So we already know all this stuff. Pathophys, they are going to have 3 shunts in the body that are going to facilitate bypassing vital organs like the lungs, since they're going to be filled up with fluid within the amniotic sac. So we can go ahead and scroll down a bit here. So these might stimulate the baby to breathe. Mostly the stretch reflexes in the lungs, mild acidosis, hypoxia, and hypothermia. We have our apneustic center that will kind of kick it into place here. So we can kind of scroll down here. We do have our fossa ovalis. So we are going to have our traditional bridging of our superior and inferior vena cava that come into the right atrium and down to the right ventricle. But we are going to have this little shunt here, and it's going to bypass our pulmonary trunk, and so it's going to go straight into the aorta branch and go into peripheral circulation. We also have another shunt, which is going to be the arteriosus, or the ductus arteriosus. This is going to be for if blood does go through the pulmonary trunk here, it's going to boop across the border and go over into the aorta, into the peripheral circulation. We have one more here, which is going to be the ductus venous, which is going to be found right here in the liver. Not going to be stressed. We have to move. Poor timing, I guess. Some congenital abnormalities, nothing too much to worry about. But there is a big chance that some of these will remain patent, and these will have to be corrected soon enough, because you are going to get a mixture sometimes of this blood. So you're going to have venous and arterious blood mixing, which is no bueno. These septal defects can increase pulmonary blood flow and can lead to CHF. Assessment-wise, we're not really going to know, other than we have a history from mom and dad that they're telling us that they were diagnosed with this stuff. But don't worry about too much. Just know that these may remain patent. So if you ever are on scene and mom and dad say they have atrial septal defects, or I don't think I have them labeled on here, but here we go, atrial stenosis, all that stuff, or tetralogy of Fallot. We got some non-cardiogenic debuffs here. So we have our diaphragmatic herniation. This is going to be an actual protrusion of our abdominal cavities that actually come up through into the mediastinum cavity, and these are going to protrude against the lung here. So they're going to create a form of obstructive shock for the baby. So we will have on our assessment, so if you are going to auscultate, you'll hear, maybe in a lung portion, you'll hear bowel sounds. Very dangerous. The more we BVM this patient without a endotracheal tube, can lead more into stomach distension. And then, since our stomach is going to be right where our lungs sit, We're going to have more protrusion into that cavity, and you're going to have decreased ventilatory compliance. End goal, we're going to need to intubate this infant. We need to bypass any structure or possibility of going into the stomach for our BVM. Meningocele. This is just going to be a form of spina bifida. This can be herniation of the spinal cord due to an improper uh, assessment. Not really assessment, but it's just going to be herniation, poor fusion during birth, so it'll kind of protrude outward. Big dangerous thing is going to be infection control for these patients, since if any bacteria or pathogenic material gets within here, it's going to go straight into the cerebral spinal fluid, and it'll go right up to the brain, and maybe we'll get a cephalic infection or meningitis or whatever coming out through the post ganglia of the spinal column. So it can go systemic pretty fast. For our treatment on this, we're going to, just as this baby is, we're going to lay him prone, and we're going to use wet sterile dressings on this patient and just try to prevent any infection. We have our omphalocele. This can be actually just herniation of our umbilical cord. So just kind of all the contents that are kind of behind it with our bowels, they're just going to be protruding through here and trying to herniate through. Just make sure you have that clamped down. Not much. It's going to be the same as this one. Just kind of lay them on their side or back and just use moist sterile dressing. Just do your best with infection control. There's not really much you can do. For the most part, neonatology on this section is going to be kind of just a refresher until we get to pediatrics. That's we're going to start grind down. So most of the stuff you're already going to know. APGAR, best thing that I've seen for this is start from the top. Just kind of expect you're going to get a 10 out of 10 score and work your way down. Look for pink above 100 BPM, coughing, crying, sneezing, active motion, strong cry. Then if you notice maybe, hey, I don't have 100 BPM, then you can negate 1 point, or the patient looks slow to me, lethargic, then bump down another one, then you get APGAR 8. It's kind of hard just to like go, 1, 2, 3, or, start from the top and then negate as you find abnormalities. With our pals, we're going to have within 100 to 60, check for their ventilatory status. Make sure they're getting oxygen exchange. Suction if you need to be. Other than that, if you're less than 60, then we're going to start initiating chest compressions. Really hoping they don't move me because I want to finish this lecture. Ensure establishing our airway here immediately after delivery. So we get the double. 231. Yeah. All right, we'll stop here for a second, and then I will probably branch off another video or part 2, whatever it may be. So give me a second here, and we'll get back on establishing the airway for a neonate.